Today I'm going to explain and demonstrate the active stage management of normal liver. So when the baby is delivered, it is already second stage management. Second stage of liver is completed. So when you are going to start the third stage of management, you just deliver the patient. So ideally, patient will be in the dorsal position or the lithotomy position. She will be clean and draped, and then the cover with the linen. Okay, and then you are the house officer or midwife or the medical officer. So this is umbilical cord. So after the delivery, you have to clamp the cord. So the baby is delivered, so you clamp the cord in one place. Then another one is you can clamp the cord, another one area. Then in that area you cut it, and then this piece will be go to the together with the baby, and then with the baby will be with the neonatologist or midwife or any other colleague. So you will be left with this. The clamp. This clamp is a spatch holding forceps. Instead of spatch holding, you can use other kind of clamp in this situation. Then this cord. So first you need to know the placenta separation, the signs of placenta separation. So the first sign is you have to wait for the gush of the blood, the lengthening of the cord. Lengthening of the cord is, how do you know lengthening of the cord? You have to make sure this clamp has to be put in near to the vulva, perineum. Then only you will know that when the placenta is separating, the cord will be lengthened. So before you remove this clamp, you have to make sure you put the pressure in the cord. Otherwise, the blood will be splattered out. So you clamp it, you put the pressure on the cord. Then you have to clamp on near the perineum. So that when the placenta is separating, you can see that this will be lengthening. So it's from there, away from the vulva and into here. So this cord, the one will be there down to the drain, so the blood will be drained to the vein. Okay, so this is one lengthening of the cord and gushing of the blood. Then at the fundus, you can see that there will be the uterus become hard and globular and rises up to the umbilicus level. Initially, the moment the baby was born, the uterus will be soft and you won't find it in on abdomen. But after a few seconds later, you can find that the uterus become rise, hard, globular, and up to the umbilicus level, because it is the upper segment start contracting, upper segment on the uterus start contracting, so that you can see that the uterus becoming hard and globular. It rises up to the umbilicus level, so that means it is around 22 to 24 weeks of gravid uterus size. Then you have to find it will be hard and it should be hard and the contracted, so that you know that this patient is not having the uterine atony. Okay, then after that you have to wait for the placenta separation. So this one side, two side, gush of fluid, gush of blood, and the lengthening of the cord, all together 4 sides. After you get it, then you have to start with the active third stage management of the liver. So in the active third stage management, there are another few steps. One is first, yes, the cord has to be clamped immediately. Then after the cord has to be cut and then whipped to the baby, and then you are left with this cord, and then inside there is a placenta. First, before all this started, you must make sure patient was given the IM Syndocino or IM Sindometrin, or mostly IM if you are delivering normally. So it should be either the thigh quadricep muscle, or then you can give it to the Madane deltoid muscle. Normally we prefer the quadricep thigh muscle. It will be given by the midwife. If not, you can give it by yourself. Okay, then after that you wait for the placenta separation side. Once there is a sign, your hands has to be at the suprapubic area. Why? Because so that if you put it on a suprapubic area, you are trying to prevent the uterine inversion when you pull the cord and a placenta. If you don't do it here, when you pull it not properly, the whole uterus inside like this supposed to be, that it will be inverted and it will fall down. That you are going to cause a uterine inversion, which will cause maternal collapse and a PPH. So when you are sure that uterus is contracting, the cord is lengthening, gush of blood is coming, then you make sure you already know that this placenta is separated. So you put your hand there and you try to pull the placenta. Okay, so you have to pull the placenta. This one is a little bit. Supposing the placenta is already here, because this is not the real patient, a little bit of difficulty. So you have to pull it when you pull it, your hand has to be, this is your cord, so this is the clamp, so the clamp will be here, so you have to put your hand here, then you pull on it only one direction, which one is a downward traction, not this way and not this way, not the circular way. This is the only one direction you pull it, so until you can see the placenta at the perineum area. At that time you can stop it, then you put your hands inside the perineum, then you can deliver the placenta with a twisted motion. So this will be the fetus side, this is going to be the maternal side. So it will be this, you have to pull it placenta this way. That's a twisted motion, so you can twist like that. Okay. And then you make sure all the membrane will be following. This is supposed to be membrane will be following, and this is going to be the maternal side, this is going to be the fetus side. So you can see all the blood vessels there. Then after that, after you finish, you can leave the placenta beside for a while. Then you make sure mother is not having a PPH. So you have to make sure that uterus is not having atony. You try massage. If there is an atony, you need to go with the PPH management. Then check for the bleeding. It shouldn't be any heavy bleeding. Then after that, you have to suture the perineal wound or episiotomy wound. Okay, and then you massage. If everything is fine, then only you can check for the placenta. After you finish all the suturing and the patient suturing complete, then you have to stabilize the patient vital sign. Then only you check the placenta. So placenta cotyledon has to be completed, and then membrane also. If you pull the membrane, there will be the 2 layer, amnion and chorion. Then only there should be only one hole where there is a baby coming. The rest have to be intact. Then you check all the cotyledon. Then only it is a complete active third stage management. Then when you check the placenta and cord, you need to check the 3 artery, 2 artery. It should be the 2 artery and 1 umbilical vein. And you need to measure the placenta weight. You need to measure the umbilical cord. Normally, we measure umbilical cord plus we put the 10 cm because the 10 cm will be together with the fetus to the baby. So plus 10 cm and the actual length. So that is your umbilical cord length. Then you need to check for the artery and 2 artery, 1 vein. And check for the because if you have one single umbilical artery, it's not the normal. And then check for any true knots and a false knot inside. And then you have to check for cotyledon and the membrane and then the fetus side and maternal side. And then only check for any cord insertion. Is it the central or is it the peripheral? Okay. Then only after you finish, then this is the third stage, active third stage management, and you check for the placenta. Then only it's all complete.